وصحبه أجمعين. حياكم الله جميعا. And on behalf of Saudi Critical Care Society, Pediatric Critical Care Eastern Province Chapter, I would like to welcome you all in this webinar. Today our webinar will be presented by our colleague from Qatif Central Hospital. And in the beginning, it's my pleasure to introduce Dr. Iman Al-Mukhtar. She's a pediatric intensive care consultant, and she's the head of PICU department at Al-Qatif Central Hospital. Dr. Al-Mukhtar, she finished her MD from King Faisal University in 2008 and obtained Saudi board in Pediatric in 2014. And she did her fellowship in pediatric intensive care medicine from King Faisal Specialist Hospital and Research Center in Riyadh in 2014. And our webinar will be presented by Dr. Iman and Dr. Fadil. He's a senior pediatric resident from Qatif Central Hospital. And the topic today is puzzling solving key is a good history taking. It's a case presentation. تفضل دكتور إيمان, Dr. Fadil, and thank you in advance.
السلام عليكم ورحمة الله. يعطيك العافية دكتور ياسر. Good evening to you all. Thank you Dr. Yasser for the introduction and for the invitation for this virtual activity. It's an honor and pleasure to join you all. Respective colleagues, greetings to my senior intensivist and all the audience. Hope this virtual meeting will be light, fruitful and beneficial for all audience, especially our residents attending. I would like to introduce our presenter, Dr. Fadil Al-Basara. He's one of our excellent senior residents at Qatif Central Hospital. He has an interest in critical care field and hope he join PICU fellowship soon, inshallah. Thank you very much, and Dr. Fadil, you can start.
Assalamu alaikum. Thank you, Dr. Iman. Thank you, Dr. Yasser, for this great opportunity. We will start our presentation today regarding this case. I was admitted to our Pedia ICU on 25th of November 2020. This patient, who was a 2-year-old Yemeni boy, was presented to our hospital ER with a chief complaint of choking, cough, and vomiting following oral intake for total 4 weeks duration prior to his presentation. Reviewing the history of the patient revealed a 2-year-old Yemeni boy who not known to have any chronic illnesses before. He was presented with a progressive onset of choking episodes. These choking episodes manifested as history of dysphagia, followed by cough till vomiting of undigested food particles following oral intake. These episodes occurred for both solid and liquid food. This episode also associated with a history of shortness of breath and while the patient in supine position, and family noticed him to used to sleep in lateral position to alleviate this shortness of breath over the last 4 weeks. Family, they report also a objective weight history of weight loss over the last 1 month, around 2 kgs, with no clear history of fever, night sweating, recent travel or contact with sick patient, and no history of upper respiratory symptoms, apnea, cyanosis, or abnormal movement, and also no history of witnessed foreign body aspiration or ingestion. For this complaint, patient sought medical advice 2 weeks prior to admission to our hospital in a local governmental hospital. He was admitted there as found to have fever in addition to his complaint, admitted with impression of pneumonia, treated with antibiotic, nebulization, and IV fluids, then discharged home. His fever resolved, but he was still complaining of vomiting episodes post-oral intake for both liquid and solid diet. He was discharged home. They stayed 12 hours in home, and as the patient still complaining of these choking episodes, not tolerating oral intake, they presented to our hospital ER for a second evaluation, a second opinion. 12 hours was discharged. In our emergency department, patient was evaluated. He was febrile, temperature 38, with relatively stable vital signs apart from tachypnea with RR 42 per minute, and saturation of 89 in room air, improved on oxygen supplementation by face mask 5 liters per minute. His ENT examination as well as cardiovascular examination was within normal, and chest examination revealed element of signs of respiratory distress in form of suprasternal and subcostal retractions, no chest wall deformities with symmetrical chest movement and expansion with equal air entry bilateral with right basal final crepitation. He was having normal perfusion with normal capillary refill time, and abdomen examination was within normal, and there was no bivalve masses. Sinus examination as well was within normal. Chest X-ray was done from ER, showing this significant finding of tracheal deviation directed toward the right side with no clear foreign body or radio-opaque opacities in the trachea or in the mediastinum. And also there was element of right middle lobe infiltrate. Based on this finding, a suspicion of possibility of mediastinal mass pushing the trachea toward the right side, Pedia ICU team was consulted from ER for admission of this patient as he was having respiratory distress, in addition to a suspicion of mediastinal mass for closer observation and securing the patient airway. Initial labs taken from pediatric ER revealed white blood cell count of 14,000 with neutrophil 60%. ESR was elevated 82, CRP 3.6, coagulation profile, blood gas, and renal functions and liver function was within normal. So the patient was decided for admission to Pedia ICU with initial impression of acute respiratory distress secondary to pneumonia, in addition to a suspicion of lower airway obstruction, as the patient was having these choking episodes, in addition to positional tachypnea that works with supine position, improved with sitting up, leaning forward, or lateral position, with a suspicion of foreign body aspiration versus ingestion, mediastinal mass with tracheal compression, and also to rule out structural congenital airway anomalies. Plan of care was consist of supportive management with IV hydration, respiratory, cardiopulmonary monitoring, and to keep saturation within normal, and start patient on empirical antibiotic, keeping the securing the airway as a top priority for this patient with a suspicion of mediastinal mass. Multidisciplinary team consultation was done from Pedia ICU that include pediatric pulmonology, ENT, and anesthesia team for securing the airway, pediatric pulmonology, considering the diagnostic work of bronchoscopy, GI team for endoscopy, and also hemato-oncology team for possibility of mediastinal mass. The agreed plan between the teams that to go for securing the airway in well-controlled setting in OR, then proceed for CT chest, and based on the CT finding to proceed for further diagnostic workup, including bronchoscopy, endoscopy, and other based on the initial finding. Airway was secured in the OR. It was a smooth intubation without difficulties nor desaturation in OR. Then also forgot to mention that Pedia IT team also was consulted and included in the management, and they consider ruling out tuberculosis, COVID-19, and pertussis. So patient intubated in OR, then after intubation taken to the CT room. The CT finding was as the following. There was mild right-sided deviation of narrow trachea with a stretched left main bronchus. This finding suggestive of tracheobronchomalacia. Also, there was bilateral scattered patchy granular glass opacities, likely infectious in nature, going with the impression of pneumonia. In addition to esophageal finding of tapered distal esophagus with proximal dilatation of the middle third esophagus, finding going with esophageal diverticulum, and they suggest further assessment by upper GI study. And also they report no significant axillary mediastinal or hilar lymph nodes nor mediastinal masses. But based on this finding, pediatric pulmonology team with the ENT team proceeded for bronchoscopy to evaluate for the possibility of foreign body aspiration in the trachea or the main bronchi, although it was not apparent in the initial CT report. Bronchoscopy result reported as there is no tracheoesophageal fistula nor foreign body in the trachea or the two main bronchi, with evidence of external compression on a long segment of the posterior lateral wall of the trachea, just above the carina. This area of narrowing was not collapsing or expanding with changing in pressure, like a typical behavior of tracheomalacia. So the impression is going with external compression rather than a tracheomalacia. And this finding necessitates further evaluation and reviewing the CT again, and also reviewing the history again with the family for possibility of foreign body ingestion. So the updated impression based on the initial workup, and that includes CT and bronchoscopy, the possibility of congenital structural airway anomalies was ruled out, and also mediastinal masses was ruled out. Foreign body aspiration also ruled out by bronchoscopy, but ingestion is still one of the possibility. So discussion with the radiologist based on bronchoscopy finding and to review suspicious lesion in the CT, I will show just in a couple of minutes, and also disclosure to the family and update them based on the current finding and gather more detailed history. As there's a suspicion of foreign body ingestion in the esophagus and expected prolonged MBO time, TPN was started for the patient. Reviewing again the history with the family and the mother, the family start to recall an event occurred 8 months ago, 8 months prior to the presentation, that the patient was playing, and then suddenly he developed a choking episode manifested as recurrent cuff till facial cyanosis resolved by vomiting. The initial event was unwitnessed, but as the patient, he vomited and regained his color, regained his activities, and he told the families decided not to start any medical evaluation at that time, as the patient was doing well. About 4 to 6 months later, 2 to 3 months prior to presentation to our hospital, he started to have infrequent episode of cough associated with choking and vomiting following solid food intake. It was on and off once, twice a week. For that reason, they decided to go for further evaluation in a private hospital. They were reassured at that time, provided nebulization and discharged home. Then these episodes of choking become more progressive, occur on daily basis until 4 weeks prior to presentation, when it was involving both solid and liquid food intake. For that reason, they were admitted in local governmental hospital, as we mentioned in the beginning of the presentation. Then the patient, after discharge from local governmental hospital, presented to our ER in 25th of November. With this detailed history, we proceeded to consult the Pedia surgery team as well as GI team for possibility of foreign body ingestion and return foreign body in the esophagus. And also the CT was reviewed again based on the based on the bronchoscopy, reviewed with the Pedia pulmonologist and also Pedia radiologist. It showed a linear hyperdensity in the upper third of the esophagus, compressing the trachea, as in this video. Coronal view showing a linear hyperdensity area extended from the esophagus and touching the wall of the trachea. This is from sagittal view. It's linear hyperdense lesion. It was measuring around 2 to 3 cm from the esophagus and compressing the trachea. The updated CT report based of reviewing this finding in considering the clinical finding, the updated report was as the following. There was a linear hyperdensity seen in the lumen of the posterior wall of the upper thoracic esophagus measuring about 2 cm in length, 2 cm below the level of thoracic inlet. It crossed the posterior lateral wall of the esophagus with a possible of tracheal perforation about 1 cm above the carina. These findings suggest upper thoracic esophageal foreign body with contained esophageal perforation and possible tracheal perforation and surrounding inflammatory process. Based on this updated finding, patient planned for diagnostic endoscopy followed by surgical intervention based on the finding of endoscopy. This is the timeline. 4th day of admission, catecholaminar refractory shock with episode of severe bradycardia and acute desaturation requiring escalation of his respiratory support, including increasing the PEEP up to 8 and pressure up to 26 to improve this episode of desaturation, and the repeated chest X-ray revealed right middle and lower lobe and also extended to the upper lobe collapse. That improved with the ventilator adjustment. His catecholaminar refractory shock required fluid resuscitation followed by epinephrine and norepinephrine to control his sepsis. And in the next day, the 5th day of admission, diagnostic endoscopy done at bedside revealed retained foreign body in the esophagus. It looks metallic and sharp. Sorry. So based on that finding, the ultimate plan was to go for. It was difficult to be manipulated and removed at bedside, according to the GI team, and preferred to be done in well-controlled setting in OR with a backup Pedia surgery as possibility of esophageal perforation plus minus tracheoesophageal fistula that was not apparent in the initial bronchoscopy and also the endoscopy. So the plan was to go for foreign body removal in OR with backup Pedia surgery for further intervention based on the finding of foreign body removal. Post this endoscopy in the early morning of the next day, the 6th day of admission, 2nd of December, we face difficulties in maintaining the saturation of this patient. There was remarkable abdominal distension and also apparently gaseous bowels apparent in the X-ray, with persistent right middle and lower lobe collapse, necessitate increase in the FiO2 up to 80 to maintain his saturation. And also the OGT drain that was connected in the collection bag was full of gas. This finding was suggestive of possible active tracheoesophageal fistula after the initial manipulation during the endoscopy. So Pedia surgery team updated about this finding, and his ventilation improved with manual deflation of the bowel, and then patient taken to the OR in the early morning. Intraoperative finding: the operation was done in 2 steps. Step 1 was endoscopic removal of the foreign body, and the finding was an inflamed area with granulation tissue just at a level of 1 cm from the incisor, with a metallic sharp end piece penetrating the wall of the esophagus and entering to the trachea. And the final impression is esophageal foreign body. They successfully removed the foreign body from the esophagus. It was metallic looks like soda can aluminum cover with a sharp edges that was penetrating the wall of the esophagus, extending to the trachea. Finding after removal reveal around 3 cm opening in the esophageal wall and communicating fistula toward the trachea, which was also around 2 cm. So after the removal of foreign body, anesthesia team faced difficulty in ventilating this patient, and he developed a severe desaturation that was refractory to increase in FiO2 and pressure. And it was followed by arrest required resuscitation. Anesthesia team, they pushed the endotracheal tube based on this finding to the right main bronchus, and they achieved ROSC after 3 minutes of active resuscitation. Saturation improved, and patient planned for right-sided thoracotomy for the correction of tracheoesophageal fistula. Stage 2, the thoracotomy, right thoracotomy done, the fistula closed, measuring around 3 cm for tracheal fistula, and esophageal fistula also around 3 cm. During the OR, patient arrested for a short period and required resuscitation and recovered. Chest tube inserted, and the patient transferred to the recovery room and followed by the Pedia ICU. Total duration of anesthesia and intervention was around 10 hours. Then patient transferred to the Pedia ICU, received in the Pedia ICU in hemodynamically stable condition on both epinephrine or norepinephrine. Heart rate was 120 with the maintained blood pressure and saturation on FiO2 45, with the BIB of 5, BIP of 16, with normal initial blood gas of 7.35, with CO2 of 44, bicarb of 24, with initial lactate of around 3, that subsequently improved down to 1 with normal urine output. This is the X-ray post OR. After that, patient received the post-operative care with a plan of weaning and to get rid of the ventilation. Just patient went into a stormy course after the after the OR. He was showing initial stable course with successful weaning from the ventilation till the 6th day post-operatively. He developed an episode of air leak and complicated pneumonia, require insertion of second chest tube. The collection in the from the chest drain showed multiple growth of Enterobacter colwaki, Elizabeth King meningoseptica, and Candida tropicalis, treated with consultation of ID team for the suitable antimicrobial therapy. And also patient had another clinical sepsis requiring inotropes, both epinephrine and norepinephrine, for total 10 days. Around 10 days after post-OR, there was an impression of query refistulization as a post-surgical complication. This initial impression was based on acute deterioration in the patient condition with sudden abdominal distension and gaseous abdomen in the X-ray. For that reason, Pedia surgery team was updated, and the plan was to go for conservative management and follow-up CT chest to evaluate the surgical site again, and to go for endoscopy and bronchoscopy. The follow-up CT also showing an area of possibility of refistulization between the trachea and the esophagus at the same level of previous operation, in addition to complicated pneumonia and possible bronchopleural fistula. For that reason, after stabilization of the patient, clinical sepsis, and also controlling the infection, patient underwent diagnostic endoscopy and bronchoscopy to evaluate the site of operation. And the report from endoscopy and bronchoscopy revealed a healed a healed wound with no active fistula and no active leak for both from both sides, esophagus and bronchus. Subsequently, the patient show a relative stable condition and underwent successful weaning till the day 24th of December, when he was extubated to high flow nasal cannula, and then 25th of November was the last date of fever. Patient completed a course of antibiotic and also antifungal therapy for total 2 weeks from the percent of the fever. This is a graph showing the ventilation chart and the respiratory support that was required for the patient. The first few days prior to OR, he was requiring FiO2 ranging between 40 to 85. This the day prior to taking the patient to the OR, with requiring higher PEEP from around 8 with a pressure of 22. Subsequently, post-OR, the patient was successfully weaned from the FiO2 and pressure as well as PEEP until the 9th of December, when the era of query revascularization and complicated pneumonia occur. Patient had increased in FiO2 requirement, then subsequently successfully weaned from ventilation and sedation as well. After that, active physical rehab and feeding started for the patient, as the patient was on required prolonged ventilation, prolonged sedation, and muscle relaxant. He was weak and required physical rehabilitation. CNS status evaluated multiple times and sedation holidays provided for the patient to evaluate his CNS functions and CNS status. He was having only weakness. His reflexes was intact, and pupils and CNS examination was within normal, which is going with critical illness myopathy. Nasojejunal feeding started 10 days after the OR, followed by gradual weaning from the ventilation until extubation. 4th of January, patient underwent upper GI esophagogram to evaluate and to cut the era of possibility of leak or revascularization. Upper GI esophagogram revealed normal healing process with normal. It was normal without any active fistula or any active leak from the esophagus to the mediastinum nor to the trachea. So for that, oral feeding gradually introduced and started. And the patient later on transferred out from the Pedia ICU with a total ICU stay of 40 days, transferred to the ward to complete his physical rehab. ENT evaluation of the upper airways revealed a left vocal cord immobility, which is most likely secondary to prolonged intubation and ventilation. And subsequently, patient discharged from the hospital on 16th of January in a stable condition. The status of the rehabilitation program provided for the patient include physiotherapy to improve the muscle power and also to regain his functional mobility, in addition to play therapy to alleviate the anxiety during the prolonged ICU stay and separation from the family. That was also successful in keeping the patient calm without agitation. Occupational therapy and speech therapy was team was consulted, and enteral feed rehabilitation and swallowing also started. Based on the ENT, based on the finding of left vocal cord immobility, the plan was to go for thickened oral feed to avoid the risk of aspiration, in addition to continuing on the patient on proton pump inhibitor, and to continue the follow-up of the patient with ENT, Pedia surgery, and Pedia pulmonology team, and also the rehabilitation team. This is the status of the patient prior to discharge. He was shiny and smiled. He was able to sit without support and able to stand and walk for 10 steps with support. And yesterday, he was seen in our Pedia pulmonology OPD. He was active, able to walk without support, and start to regain his to regain his weight. He almost gained around 4 kgs. This is regarding our patient, and it was also showing a similarity with multiple case reports of a soda can tab ingestion. And we would like to highlight this case report that was reported by Dr. Sami Majid, Dr. Akram Jahdali, and Dr. Ahmed of a 6-year-old boy who had unwitnessed foreign body aspiration and was presented for 6 months of going and visiting the emergency rooms for evaluation of chronic cough until he was landed in the Pedia pulmonology team, and the suspicion of foreign body in the trachea was raised. Bronchoscopy revealed the presence of retained foreign body in the esophagus that was complicated also by the tracheoesophageal fistula, with a similar stormy course similar to our patient. This is regarding the presentation of our patient, and thank you for your time.
Thank you very much, Dr. Fadel, for your presentation. I will leave the mic for Dr. Yasser for moderating if there is any questions or comments regarding the case.
Thank you, Dr. Fadel, and thank you, Dr. Iman. Very interesting and challenging case with very excellent and happy outcome. I think the chat box is disabled because maybe I don't know, security issue. So I don't know if Rosaline, I don't know if we can able to open the chat box for any question from the colleagues, or we're going to conclude our presentation for today.
Yes, doctor. It is recorded, doctor.
So the chat box is disabled, right?
Chat box. I don't know. I don't know the chat box. How it will. I can't see the chat box.
So maybe I'm gonna wait for. Yeah, that's right. Maybe I'm gonna wait for maybe 1 minute. If anyone has any question, he can send it to me through WhatsApp, so I can read it for the speaker and Dr. Iman.
Sure, doctor. One comment regarding the patient. The challenge about the history of the patient was, as mentioned by Dr. Fadel, the family were Yemeni and they had language barrier, and the suspicion of foreign body was raised initially from the day 1 of admission to the ICU, while the family was denying any episodes of choking. Subsequent collection of the history revealed the mother recalled one incident that happened a long time ago. And in regard of the complexity of the case, that the foreign body was not shown in the CT because it was not metallic. It was aluminum covered plastic piece. It's a sharp juice can, similar to the Pepsi can. I would like to thank Dr. Sami Majid, our colleague in Johns Hopkins, regarding their case. It's almost similar, but the differences between the metallic sharp object that was metallic in their case, while in our case was difficult to be visualized in the CT, even with the contrast, because it was not radio opaque. So the other point is the challenging ventilation pre-op and post-op. The patient reached a point of FI2 requirement up to 100%, almost needed an oscillator, and he has very critical condition. Discussion regarding the ideal situation of if the patient needs further or higher center for bronchoscopy guided intubation and blockage of the fistula through balloon. as interventional procedure was raised and patient condition was not allowing to refer him to higher center at that time. Also, other point of patient condition to put him on ECMO or bypass during his most sickness days, but thank God he passed through a very stormy course, and his outcome became very good for his situation. Our message is obtaining history always and high index of suspicion of foreign body in community-based services, hospitals, very common in the pediatric age group, even if it's not mentioned in the history, and high index of suspicion, widening the differential diagnosis always will get you into a long list of differential excluding in and out, and will take you through the most probable diagnosis.
Thank you, Dr. Iman, for your comment. I think we're gonna conclude our meeting today. And at the end, I'm very thankful for you, Dr. Iman, Dr. Fadel, for the presentation and for the hard work you guys did for this case. And also, I would like to thank all the audience, the 200 plus participants in this webinar. And hopefully, we're gonna see you guys in the upcoming webinar. Thank you all, and Assalamu alaikum.
Thank you very much.
Thank you, doctor. Bye. Thank you all.